Welcome to the Deep Dive, where we break down complex surgical topics to help you ace the FRCS plastic surgery exam. Today, we're diving into velopharyngeal dysfunction, or VPD for short.
And understand the terminology is absolutely crucial.
So let's start there.
All right, so VPD, it refers to any abnormal function of the velopharyngeal mechanism. And we often break it down into three subcategories: insufficiency, incompetence, and mislearning. These terms actually tell us a lot about the underlying cause.
Okay, so insufficiency. That means there's a structural problem.
That's right.
Incompetence means it's neurological.
Exactly.
And mislearning, well, it suggests a more behavioral issue.
Precisely.
So we've got our terminology straight. What about the speech characteristics? What should we be listening for in a patient with suspected VPD?
Well, there are a few key things. Nasal emission, especially during those pressure consonants, and then hypernasality or even hyponasality, which affect the resonance of vowels.
Okay, that makes sense. What about that sort of rustling sound you sometimes hear, especially with consonants like B or D?
Ah, yes, that's what we call nasal rustle or sometimes turbulence.
Interesting. Any other speech clues we should be aware of?
Definitely. Look out for things like facial grimacing. And then you have nasal substitution, where sounds like B might become M. And of course, compensatory articulation, which can really distort those sibilants, the Is and Z's sounds.
So a whole variety of speech clues can point us toward VPD, but to really understand how these problems arise, we need to delve into the anatomy.
Absolutely. The anatomy is key. And when we're talking about the velopharynx, it's the dynamic anatomy that's really crucial.
Dynamic anatomy meaning?
Meaning how these structures actually move during speech. Think about the velum, the posterior pharyngeal wall, and the lateral pharyngeal walls, all working together to close off that velopharyngeal port.
So they all have to coordinate to create that seal.
Precisely. You can almost visualize it like a drawstring bag cinching closed.
I like that analogy. And there are different ways this cinching can happen, right?
You got it. We call these closure patterns, and you have several types. The coronal pattern, where the velum moves up against the pharyngeal wall. The sagittal pattern, where the lateral walls move inward. Then you have the circular pattern, which combines both of those movements. And of course, there are variations involving passavant's ridge, or sometimes you get a bow tie shape. Understanding these patterns helps us pinpoint exactly where the closure problem lies.
So if this drawstring doesn't close properly, we get VPD. What are some of the things that can cause these closure problems in the first place?
Well, the causes generally fall into two broad categories. You have cleft palate, and then you have non-cleft palate causes.
Okay, let's start with cleft palate.
All right. So in cleft palate patients, we have to think about things like unrepaired palates or even palates that are just too short. Immobility from scarring can also be a factor, as can fistulas. And we even see VPD sometimes after midface advancement, particularly in patients who had borderline VPD before the procedure.
So all these disrupt that structure needed for proper closure.
Exactly. Now, with the non-cleft palate causes, things get a bit more diverse. Neuromotor issues, like what you see in traumatic brain injury, myasthenia gravis, or cerebral palsy, can impair muscle control. And certain syndromes, like velocardiofacial syndrome or Vader association, should also be on your radar.
So anything that affects the nerves or muscles involved in closure can contribute.
Right. And then you have what we call mislearning.
Mislearning.
Yes, where it's a learned behavior rather than a structural or neurological issue. For example, a child might develop phoneme-specific nasal emission, where they only have nasal air escape with certain sounds.
So it's like a habit they've picked up.
Precisely. And let's not forget about post-adenoidectomy VPD. Removing the adenoids can sometimes disrupt the velopharyngeal mechanism, particularly if the adenoids were helping with closure before. Tonsillar hypertrophy can also mechanically obstruct closure. And even some surprising things, like extensive wind instrument playing, have been associated with VPD.
Wow, that's quite a range of causes. So how do we systematically evaluate a patient when we suspect VPD?
Well, ideally, evaluation starts early, around 2 to 3 years of age. And we begin with a thorough intraoral exam.
Looking for
Anything unusual, really. Occlusion problems, palatal abnormalities, checking the tonsils for hypertrophy, assessing the pharyngeal wall motion, anything that might give us a clue.
So we're essentially looking for any signs that might explain a closure problem.
Exactly. And then we move on to the perceptual speech evaluation. This is where we listen carefully for those speech characteristics we discussed earlier. The nasal emission, hypernasality, and so on.
Using both those provocative samples with specific phrases and spontaneous speech, right?
You got it. Both are important. The perceptual speech evaluation helps us confirm the presence of VPD and gives us a sense of its severity.
But to really understand the cause and get some objective measurements, we need to go further.
Absolutely. That's where instrumental assessment comes in.
Like,
Well, one of the gold standards is multi-view video fluoroscopy.
and that's where we use X-rays to visualize the velopharyngeal closure during speech.
Exactly. So we can actually see that drawstring in action, or rather, the lack of action.
Very helpful. What other instrumental assessments do we have at our disposal?
Well, there's nosometry, which measures airflow to calculate the size of the velopharyngeal port. And this actually correlates quite well with the severity of hypernasality.
So the bigger the port, the more hypernasality.
Generally speaking, yes. And then we have nasendoscopy, which lets us directly visualize the velopharyngeal port using a small camera.
Ah, so we can see the closure patterns and any anatomical issues up close.
Precisely. Each tool provides a different piece of the puzzle.
And what about MRI? Does that have a role in VPD evaluation?
It can be helpful as an adjunct, particularly in cases where we suspect vascular anomalies or when we need to get a really detailed look at the velar muscles. MRI, and particularly MRA, can be very useful in those situations.
Well, we've got a whole toolbox of assessments to help us understand VPD. Once we've got that detailed evaluation, we can then decide on the most appropriate treatment approach.
Exactly, and it's important to remember that treatment always starts conservatively. Speech therapy can be very effective, especially for intermittent VPD, or as an initial step in more pervasive cases.
So retraining the muscles and improving those speech patterns.
You got it. And if speech therapy alone isn't enough, then we might consider prosthetic management.
Prosthetic management meaning?
Devices like palatal lifts, velopharyngeal obturators, or a combination called a lift orator, these can really help improve closure. The type of prosthesis chosen depends on the specific anatomy and the nature of the VPD.
So we try to address the problem without surgery whenever possible.
Absolutely. But of course, if conservative approaches fail or are unsuitable, then we might consider surgical treatment.
And what are the surgical options for managing VPD?
Well, there are several. One option is the furlough double opposing Z-plasty, or IVV, which you can read about in more detail in Chapter 25. Then there's sphincter pharyngoplasty, where we essentially create a dynamic muscular sling at the back of the throat to improve closure. And lastly, we have the posterior pharyngeal flap, where we use tissue from the back of the throat to bridge the gap in the velopharyngeal port.
And the choice of surgical procedure depends on?
A lot of factors, of course. The size and location of the closure deficiency are important considerations, but a recent meta-analysis has actually challenged that traditional approach of selecting procedures solely based on those factors. The debate about the optimal selection method is ongoing. Regardless of the specific procedure, thorough preoperative assessment and planning are absolutely crucial.
Making sure we address things like hypertrophied tonsils or adenoids before VPD surgery to prevent complications.
Precisely. Now let's take a closer look at these surgical procedures, starting with sphincter pharyngoplasty.
Okay, so how does sphincter pharyngoplasty work?
Well, the basic idea is to create a new muscular doorway, so to speak, at the back of the throat. We want to help control airflow. We do this by elevating flaps of muscle and mucosa from the lateral pharyngeal walls and attaching them to the posterior pharyngeal wall, creating a more effective sphincter.
So it's about creating a new, tighter opening.
Exactly. And the specific technique can vary. For example, the Heinz technique utilizes the salpingopharyngeus muscles, while the Orticochea technique uses the palatopharyngeus muscles. The Jackson and Silverton technique is similar to Orticochea, but with a different flap orientation. And the Moore technique attaches the flaps to the back of the velum instead.
So we're choosing the right building materials and the right approach based on the individual patient.
Precisely. Now let's move on to the posterior pharyngeal flap procedure.
How does that one differ from sphincter pharyngoplasty?
Well, with the posterior pharyngeal flap, we're essentially borrowing tissue, including both mucosa and muscle, from the back wall of the throat, the posterior pharyngeal wall, and using it to bridge the gap in the velopharyngeal port. This flap is then carefully attached to the soft palate.
So instead of building a new doorway, we're building a bridge to close the gap.
That's a great way to visualize it. And just like with sphincter pharyngoplasty, there are variations in how this is done. We might use a superiorly based flap or an inferiorly based flap, maybe add some nasal mucosal lining flaps, adjust the width based on lateral wall movement, or even use two transversely based flaps. The key is to tailor the technique to each patient's unique anatomy.
Sounds like customization is key for both procedures.
Absolutely. Now, there's another option, though it's less common, called posterior pharyngeal wall augmentation.
What's the idea behind that one?
Well, instead of creating a new structure, we're trying to bolster the existing one. We basically place materials like cartilage or fascia behind the back wall of the throat to try to improve closure.
So sort of like adding some extra padding?
Exactly. However, this approach has had limited success and carries a higher risk of complications compared to the other techniques. So it's not usually our first choice.
Makes sense. So we've talked about the surgical options. What about postoperative care? What are the key aspects to remember?
Postoperative care is crucial for good outcomes. Airway monitoring is absolutely paramount, especially in infants with Robin sequence.
Right, because their airways are already narrower than usual.
Exactly. So we need to be extra vigilant in these cases. Continuous pulse oximetry is a must, and careful sedation management is also key.
So vigilance is key in the immediate postoperative period. What about pain management?
Pain management is another top priority. We usually use a combination of analgesics to ensure the patient's comfort and to minimize the risk of any complications.
And what about feeding after surgery?
We typically start with a liquid diet and gradually progress to soft foods as healing occurs. It's important to avoid anything hard or crunchy that could disrupt the surgical site.
So a gentle and gradual approach to eating is best.
Exactly. And when it comes to discharge criteria, we want to see adequate airway protection, good pain control, and tolerance of oral intake. We also make sure that parents or caregivers understand the postoperative instructions and know what signs to watch for.
So we're looking at monitoring, pain relief, dietary management, and education. A multifaceted approach.
Precisely. Now, even with meticulous care, complications can occur.
And what are some of the complications we need to be aware of?
Well, one of the most serious is sleep-disordered breathing, including acute OSA.
Which can be life-threatening.
It can be, especially in infants and young children, so we need to be very observant for any signs of breathing issues.
What should we be looking for?
Things like loud snoring, pauses in breathing, restless sleep, those are all red flags that require immediate attention.
So we need to be very proactive. What other complications should we keep in mind?
Wound dehiscence is another one to be aware of. That's where the incision separates.
And what causes that?
It could be due to infection, tension on the wound, or just problems with wound healing in general. If dehiscence occurs, it can lead to persistent VPD and may require further surgery.
So careful surgical technique and wound care are crucial to prevent this.
Absolutely. And then there's hyponasality, which is too little nasal resonance. It's basically the opposite of hypernasality.
So if the velopharyngeal port is overcorrected during surgery and it closes too tightly.
Exactly. And while rare, injury to an anomalous internal carotid artery is a potential risk, particularly during procedures that involve the posterior pharyngeal wall.
That sounds concerning.
It is a rare complication, but it's something we need to be aware of. Thorough anatomical knowledge and meticulous technique are essential to avoid this.
So vigilance and preparedness are key even after the surgery is complete.
Absolutely. Now, before we move on, let's recap what we've learned so far.
Sounds like a good plan. What are the key takeaways for the FRCS exam?
First, remember those different types of VPD, the insufficiency, incompetence, and mislearning, and their distinct causes.
We covered those in detail earlier.
Right. Then, understand the anatomy and physiology of velopharyngeal closure, including the different closure patterns and the muscles involved.
Coronal, sagittal, circular, and so on.
Exactly. Be familiar with the range of causes of VPD, both cleft and non-cleft related. And finally, be prepared to discuss the evaluation and treatment options, including speech therapy, prosthetics, and those various surgical techniques.
It's all about having a comprehensive understanding of VPD and its management.
Precisely. Now, let's transition to discussing the furlough double opposing Z-plasty in a bit more detail.
Okay, so what's the key principle behind the furlough palate-oplasty?
Well, the furlough palatoplasty, it primarily addresses palatal repair in cleft palate patients, but it can also improve velopharyngeal closure as well. It involves creating two opposing Z-plasties, one on the oral surface of the soft palate and one on the nasal surface. This repositioning lengthens the palate, which helps with closure, and it also creates a more functional velar sling.
So we're essentially rearranging the existing tissues to improve their function.
That's a good way to put it. Now let's talk about post-operative care following a furlough palatoplasty or any other VPD surgery.
What are the most important aspects of post-operative care to remember?
Well, as we touched on earlier, airway monitoring is absolutely critical, particularly in those infants with Robin sequence. They're already predisposed to airway compromise.
Because their airways are already narrower than usual.
Right, exactly. So we need to be extra vigilant in those cases, and we've got to be alert for any signs of respiratory distress. Pain management is another top priority, and we'll often use a combination of medications to keep the patient comfortable and to minimize the risk of any complications.
And what about feeding after the procedure?
We typically begin with a liquid diet and then gradually progress to soft foods as healing progresses. It's important to avoid anything hard or crunchy that could irritate the surgical site.
Makes sense. So a gradual and gentle approach to eating is best.
Yes. And when it comes to the criteria for discharge, well, we want to see adequate airway protection, good pain control, and of course, the ability to tolerate oral intake. We also want to make sure that parents or caregivers understand the postoperative instructions and know what signs to watch for.
So we're looking at monitoring, pain relief, dietary management, and education. A multifaceted approach.
Precisely. Now, even with the best care, complications can sometimes occur.
What are the most common complications we should be aware of after VPD surgery?
As we mentioned before, sleep-disordered breathing, including acute OSA, is a significant concern, particularly for those with pre-existing airway issues.
So careful monitoring is crucial, even after surgery.
Absolutely. Another complication is wound dehiscence. That's where the surgical incision separates.
And that can lead to persistent VPD.
Yes, and potentially require further surgery. Another potential problem is hyponasality. That's where the speech lacks nasal resonance.
So the opposite of hypernasality.
Yes, exactly. Hyponasality can happen if the velopharyngeal port is overcorrected during surgery, leading to excessive closure.
Meaning it closes too tightly.
Precisely. And while it's rare, we also need to be aware of the risk of injury to an anomalous internal carotid artery.
That sounds concerning.
It is a rare but potentially serious complication that can occur during procedures involving the posterior pharyngeal wall. A thorough understanding of the anatomy and careful surgical technique are essential to minimize this risk.
So vigilance and preparedness are key.
Absolutely. Now, to summarize our deep dive into VPD, let's review the most important points for exam preparation.
Sounds like a good plan. What are the key facts about VPD that we need to know for the FRCS exam?
First, be able to define VPD and its subtypes insufficiency, incompetence, and mislearning. Understand the differences between these terms.
We covered those in detail earlier.
Next, have a solid grasp of the anatomy and physiology of velopharyngeal closure, including those different closure patterns and the muscles involved.
Coronal, sagittal, circular, and so on.
Exactly. Be familiar with the various causes of VPD, both cleft and non-cleft related, and know the evaluation process, including perceptual speech evaluation and instrumental assessments like video fluoroscopy and nasometry.
We went through those step by step.
Finally, be prepared to discuss the treatment options for VPD, ranging from conservative measures like speech therapy to surgical procedures like sphincter pharyngoplasty and posterior pharyngeal flap.
So it's all about having a comprehensive understanding.
Exactly. And remember, meticulous postoperative care is paramount to ensure optimal outcomes and to minimize complications, no matter which treatment path is chosen.
Great advice. This deep dive has been incredibly helpful. I feel much better prepared for the FRCS exam now.
Glad to hear it. Best of luck with your studies.
Now, before we wrap up this part of our deep dive, let's shift our focus to a critical aspect of patient care after VPD surgery: monitoring for complications.
Yes, monitoring for complications is crucial. One of the most concerning is sleep-disordered breathing, particularly acute obstructive sleep apnea, or OSA.
That sounds serious.
It can be, especially in infants and young children. Therefore, close observation and monitoring are essential in the immediate postoperative period.
What signs should we be looking for?
Loud snoring, pauses in breathing during sleep, restless sleep, and sweating are all red flags. If any of these symptoms are present, further evaluation and intervention may be necessary.
So we need to be proactive.
Absolutely. Another complication to be mindful of is wound dehiscence, where the surgical incision separates.
What causes wound dehiscence?
Several factors can contribute to dehiscence, including infection, tension on the wound, or problems with wound healing in general. If it occurs, it can lead to persistent VPD and might require additional surgery.
So meticulous surgical technique and careful wound care are essential to prevent dehiscence.
Precisely. Another potential issue is hyponasality, where there is insufficient nasal resonance in the patient's speech.
So the opposite of hypernasality.
Yes, exactly. Hyponasality can happen if the velopharyngeal port is overcorrected during surgery.
Meaning it closes too tightly.
Precisely. While not as common as other complications, we also need to be aware of the risk of injury to an anomalous internal carotid artery.
That sounds concerning.
It is a rare but potentially serious complication that can occur during procedures involving the posterior pharyngeal wall. A thorough understanding of the anatomy and careful surgical technique are crucial to minimize this risk.
So being vigilant and prepared for any eventuality is key.
That's the main takeaway. Now, to wrap up this section of our deep dive into VPD, let's revisit the most important points for exam preparation.
Sounds good. What are the key takeaways for the FRCS exam?
First, remember the definitions of VPD, velopharyngeal insufficiency, incompetence, and mislearning. Be able to explain the differences between these terms.
We covered that in detail.
Next, you need to have a solid grasp of the anatomy and physiology of velopharyngeal closure. This includes knowing the muscles involved and the different closure patterns.
Coronal, sagittal, circular, and so on.
Yes. You should also be familiar with the various causes of VPD, both cleft and non-cleft related, and understand the evaluation process, including perceptual speech evaluation and instrumental assessments such as video fluoroscopy and nisometry.
We went through those step by step.
And lastly, be prepared to discuss the different treatment options available, from conservative measures like speech therapy to surgical procedures like sphincter pharyngoplasty and posterior pharyngeal flap. Be sure to know the indications, advantages, and potential complications of each approach.
It's all about having a comprehensive understanding.
Exactly. And no matter which treatment path is chosen, meticulous postoperative care is essential to optimize outcomes and minimize the risk of complications.
Excellent advice. This deep dive has been incredibly helpful. I feel much better prepared for the FRCS exam now.
Glad to hear it. Best of luck with your studies.
And to all our listeners, thanks for joining us on the deep dive. We'll continue our exploration of VPD in part 2.
Let's pick up our discussion on VPD and delve a bit deeper into the furlowed double opposing Z-plasty.
Right, the technique you mentioned earlier for cleft palate repair.
Exactly. And as you know, the furlow palate is a really versatile technique.
So it addresses both the cleft palate and the velopharyngeal insufficiency.
Precisely. It achieves this by creating two opposing Z-plasties, one on the oral surface of the soft palate and one on the nasal surface. This repositioning actually lengthens the palate, which helps with closure, and creates a more functional velar sling, improving that muscular action.
Essentially, it's a strategic rearrangement of those palatal tissues.
That's a great way to put it. Now, regardless of which specific surgical technique we use, post-operative care for VPD surgery generally follows a similar path.
What are the key things we need to keep in mind?
Well, airway monitoring is absolutely paramount, especially in infants with Robin sequence.
Right, because they're already prone to airway obstruction.
Exactly. And surgery can sometimes exacerbate that risk, so we need to be extra vigilant in these cases.
Makes sense. So what does that vigilance look like?
Well, continuous pulse oximetry is a must, and careful sedation management is also key. We want to make sure we're not further compromising their airway.
So airway, airway, airway. Got it.
Yeah.
What about pain management?
Another top priority, of course. We typically use a combination of analgesics to ensure the patient's comfort and minimize the chances of any complications arising from pain.
Okay, that makes sense. What about feeding after surgery? When can they start eating again?
We usually start with a liquid diet, and then as healing progresses, we gradually introduce soft foods. The key is to avoid anything hard or crunchy that could irritate or disrupt that surgical site.
So a gradual and gentle approach is best.
Precisely. Now, before we discharge a patient after VPD surgery, we want to make sure they meet certain criteria.
What are we looking for?
Adequate airway protection, of course. That's always number one. We also want to see good pain control and the ability to tolerate oral intake without any issues.
Essentially, we want to make sure they're stable and on the road to recovery.
Exactly. And we also make sure that parents or caregivers understand the post-operative instructions, what signs to watch for, when to call the doctor, that sort of thing. Education is crucial.
Absolutely. So we've got airway monitoring, pain management, a gradual return to feeding, and clear communication with the family. But even with all of that, I imagine complications can still arise.
Unfortunately, yes. Even with the most meticulous care, complications can happen.
What are the most common ones we need to be prepared for?
Well, as we discussed earlier, sleep-disordered breathing, including acute OSA, is a serious concern, especially in patients who are already predisposed to airway issues.
So those with Robin sequence, for instance.
Exactly. So we need to remain vigilant even after the surgery is complete.
What are the warning signs? How do we know if something's wrong?
Well, things like loud snoring, pauses in breathing during sleep, restless sleep. Those are all red flags. And sweating, especially during sleep, can also be a sign of trouble.
So those are things that should prompt further evaluation.
Absolutely. Now, another complication that we sometimes see is wound dehiscence.
That's where the surgical incision separates.
Exactly.
And what causes that? Is it a problem with the surgical technique?
Well, it could be, but there are other factors that can contribute to dehiscence as well. Infection, for example, or too much tension on the wound, or sometimes it's just a general problem with wound healing.
And if dehiscence occurs, what then?
Well, unfortunately, it can lead to persistent VPD, and that often means we need to go back in and do another surgery to repair the wound and address the ongoing velopharyngeal insufficiency.
So meticulous surgical technique and careful wound care are really important for preventing this complication.
Precisely. Now, another potential complication is hyponasality.
Hyponasality.
Yes, it's basically a reduction in nasal resonance during speech, so the opposite of hypernasality.
So instead of too much air escaping through the nose, there's not enough.
Exactly. And this can happen if the velopharyngeal port is overcorrected during surgery, meaning the closure ends up being too tight.
I see. So it's a delicate balance to achieve just the right amount of closure.
Yeah.
Too little, and you get hypernasality.
Yeah.
Too much, and you get hyponasality.
Precisely. Now, there's one more complication that we need to be aware of, although it's thankfully quite rare.
And that is,
Injury to an anomalous internal carotid artery.
wow, that sounds serious.
It is, and it's a potential risk during procedures that involve the posterior pharyngeal wall.
So that's with the sphincter pharyngoplasty and the posterior pharyngeal flap.
Exactly. The internal carotid arteries usually run up the sides of the neck, but sometimes there can be an anatomical variation where one of the arteries takes a more medial course. And if that's the case, it could be in danger during these procedures.
So what can we do to prevent this?
A thorough understanding of the anatomy is crucial. We need to be aware of the possibility of this anatomical variation and look for it during our preoperative imaging. And of course, meticulous surgical technique is essential. We need to be very careful when dissecting in this area to avoid injuring any vital structures.
So vigilance and preparedness are key. We need to be aware of the potential complications and take steps to prevent them. And if they do occur, we need to be able to recognize them early and manage them appropriately.
Exactly. Now, to wrap up our discussion on VPD, let's reiterate those key points for the FRCS exam.
Sounds good. What are the absolute must-know facts about VPD?
First, make sure you can define VPD and its subtypes. Velopharyngeal insufficiency, incompetence, and mislearning. Be able to explain the differences between those terms.
We covered that in detail earlier. Insufficiency is a structural problem, incompetence is neurological, and mislearning is behavioral.
Exactly. Next, you need to have a solid understanding of the anatomy and physiology of velopharyngeal closure. Remember those different closure patterns and the muscles involved?
Coronal, sagittal, circular, and all the variations we discussed.
Right. You should also be familiar with the range of causes of VPD, both cleft and non-cleft related.
From structural abnormalities and neuromotor impairments to even things like enlarged tonsils or learned patterns of speech.
Precisely. Know how to evaluate a patient with suspected VPD. That includes both perceptual speech evaluation and those instrumental assessments. Be able to describe the different methods and their indications.
Multi-view video fluoroscopy, nisometry, nistomendoscopy, each tool has its purpose.
Exactly. And finally, be prepared to discuss the treatment options for VPD. That includes both conservative and surgical approaches. Be able to explain the indications, advantages, and disadvantages of each approach.
Speech therapy, prosthetic management, furlough palatoplasty, sphincter pharyngoplasty, posterior pharyngeal flap. It's a multi-pronged approach.
Precisely. And remember, no matter which treatment path is chosen, meticulous postoperative care is paramount to ensure the best possible outcomes and to minimize those potential complications.
This deep dive has been incredibly helpful. Thank you for breaking down such a complex topic. Now for our final part, let's shift our focus to those potential complications after VPD surgery. All right, let's dive into those potential complications after VPD surgery. What are the things we really need to be on the lookout for?
Well, we've touched on this a bit already, but one of the most concerning complications is sleep-disordered breathing, particularly acute obstructive sleep apnea, OSA.
That sounds serious, especially in those younger patients.
It can be, absolutely, especially in infants and young children. So close observation after surgery is critical, especially right after the procedure. That immediate postoperative period is key.
Okay, so we're watching them closely. What specific signs should we be looking for? What are those red flags?
Well, some things are pretty obvious, like loud snoring. pauses in breathing while they're sleeping, restless sleep, and sweating, particularly if they're sweating a lot while they sleep.
Those all sound like signs we shouldn't ignore.
Definitely not. If you see any of those, you need to get further evaluation right away. You might need to intervene.
So we're being proactive. What other complications should we be thinking about?
Another one to be mindful of is wound dehiscence.
Dehiscence, meaning the incision comes apart.
Exactly.
What causes that?
It could be a few things. Sometimes it's infection. Sometimes there's too much tension on the wound. Or sometimes it's just a general issue with wound healing.
And if it happens, what are the implications?
Well, it can lead to persistent VPD, unfortunately. And that often means we need to go back in and do another surgery. We need to fix the wound, of course, but we also need to address the underlying velopharyngeal insufficiency that's still there.
So meticulous surgical technique, good wound care, those are really important for preventing this.
Absolutely. Now, another potential issue we see is hyponasality.
Hyponasality. So in essence, the opposite of hypernasality.
You got it. It's where there's not enough nasal resonance in the speech.
So too little air going through the nose instead of too much.
Precisely. And this can happen if we overcorrect the velopharyngeal port during surgery, if it ends up closing too tightly.
So it's a balancing act. Too little closure, you get hypernasality. Too much, you get hyponasality.
Exactly. Finding that sweet spot is crucial. And while rare, we also need to consider the risk of injury to an anomalous internal carotid artery.
That sounds pretty scary.
It's definitely a serious complication, and it's something that can happen during procedures involving the posterior pharyngeal wall.
So with sphincter pharyngoplasty and posterior pharyngeal flap.
Right. Usually those carotid arteries run up the sides of the neck, but sometimes one of them takes a different path, a more medial course. And if that's the case, it could be at risk during these procedures.
So how do we avoid that?
A thorough understanding of the anatomy is crucial. We have to know that this variation exists, and we need to look for it in the preoperative imaging. And then, of course, meticulous surgical technique is key. We have to be extremely careful when we're operating in that area to avoid injuring any important structures.
So always be prepared. Know the anatomy, know the possible complications, and be vigilant throughout the entire process.
Exactly. Vigilance and preparedness are key, from pre-op planning all the way through post-op care.
Excellent advice. Okay, so to wrap up this deep dive into VPD, let's go over those key takeaways for the FRCS exam one last time. What are the absolute must-knows?
All right, so first, you have to be able to define VPD and those subtypes. Velopharyngeal insufficiency, incompetence, and mislearning. Make sure you can explain the differences between them.
We cover that in detail. Insufficiency is the structural problem, incompetence is neurological, and mislearning is behavioral.
Exactly. Next up, a solid grasp of the anatomy and physiology of velopharyngeal closure is essential. Know the muscles, know the closure patterns.
Coronal, sagittal, circular, all those variations we talked about.
Right. And be sure you're familiar with the causes of VPD, both cleft and non-cleft.
Everything from structural issues to neuromuscular problems to learned speech patterns.
Precisely. You also need to understand how we evaluate a patient for VPD. That means knowing the perceptual speech evaluation and the instrumental assessments.
Multi-view video fluoroscopy, nasometry, nasendoscopy. We talked about those in depth.
Right. And finally, be ready to discuss the treatment options. We've got conservative measures like speech therapy, and then we have the surgical procedures. Be sure you know the indications, the advantages, the disadvantages, and the potential complications of each.
Speech therapy, prosthetics, furlough, sphincter pharyngoplasty, posterior pharyngeal flap, a whole range of options to consider.
Exactly. And no matter what treatment we choose, remember that meticulous postoperative care is absolutely essential. It's how we optimize outcomes and minimize the risk of those complications we've been talking about.
Couldn't agree more. This deep dive has been incredibly helpful. I feel much more confident about VPD for the FRCS exam now. Thanks for all the insights.
Glad to be of help. Best of luck with your preparation.
And to all our listeners, thank you for joining us on the deep dive. We hope you found this exploration of VPD helpful in your journey toward the FRCS plastic surgery exam.